Okay. Assalamu alaikum. This is a continuation of a case. Okay, this is a case where we had a denture that was mobile in the patient's mouth. Okay. So the patient came with what complaint, please, doctor?
Some pain in the crest of the ridge, the buccal mucosa of the left side, and lack of retention.
And lack of attention. And I told you to do this unique technique. I'm not aware of anybody is using it other than me. I always have my students have this experience of doing this at least once in one of the cases. And this is using light body rubber, and you placed it, and there are areas that were exposed. I might show you the video before we have colored them, but now they are colored with the copia pencil or a marker. We did not find a copia, so we just used markers. You asked me a good question before. Am I going to count this as an overextension, for example, here?
Yes.
Do you think it's an overextension?
No, or maybe just the material didn't flow enough. We didn't have enough
I'm
material.
going to tell you, I'm not going to count it. Why? Because for me to count it, first of all, you need to have done all of the border molds correctly. You told me you could not do the border molding correctly. Secondly, the material did not flow from the denture downwards. So I need to load the denture not only inside the denture, I need the material to flow to the outside from the beginning. So what I see that these sides are empty from the side. I'm trying to get see, it's empty. You did not have all of this filled, and this was now exposed. So I could not consider that, okay? Second, you're complaining about the material that it set slightly. You felt it not flowable as enough.
Yes.
So this will also explain sometimes the problem here. But although the material was thick, okay, I'm suspecting that it was partially set because you took some time with the mixing. Still, I have these areas exposed. What are these areas?
Negative pressure.
These are positive pressure. These are heavy pressure areas. And this is what's beautiful about this material. It shows you the negatives and shows you the positives. Okay? So for the positives now, these are areas that are overextended. How do I know? When the denture is trying to see it, these were loaded before the rest of the denture. Where should the areas of pressure be? If I was correct, I have done my denture correctly according to the selective pressure technique. Where should I see these exposed areas?
Okay.
Yes, hard palate. Hard palate away from the rugae area. I should see them here, here, and on the buccal slopes at the ridges. But here I have them on the rugae area. Okay, is the rugae area primary support area or not?
No, secondary.
It's a secondary support area. Why is that? Why is it a secondary?
It's a soft tissue, compressible.
It is compressible.
Irregular.
But the irregularity, the angle,
Force is not vertical to the
forces are not vertical. Excellent. And something
type
else.
of the bone.
No, the type of tissue is spring back. It produces a spring back action.
Yes.
So it's not compressible. I mean, I can compress it, but it will recoil quickly under the denture because it's not the same as my finger pressure. So I would suspect when you made the impression, the secondary impression, you had pressure on the anterior area. How do I overcome this? When I'm loading a secondary impression, where do I stand? In front of the patient or behind the patient?
Behind the patient.
Behind the patient. Where do I hold the tray in place?
In the back.
In the back. So my fingers will be on the molars. So if I have pressed this or loaded this inside the mouth correctly, I should see the pressure in the molar areas, not in the anterior area. So this would tell me that you were pressing on the handle more and the anterior more. You did not go back. You did not press on the molars back. Okay? A second thing, do you see this area here on the molar, underneath the molar?
Yes, it's
a sharp area, son.
Yes, it's a recent extraction area.
So what do these happen? What happens is that the empty socket is during the secondary impression was filled, but here now it's healed.
Yes.
Once you've done the delivery. So this healed socket is no longer empty or no longer concave. It's now filled in with the fibrin. So this is a positive pressure area. So what am I going to ask you to do? First of all, these pressure areas, I'm going to let you relieve them. You're going to take this out, the impression out. The marker had marked the areas that were exposed. You're going to remove from them. What are you going to remove? In the rugae area, you're going to remove the tips of the rugae area. So you will not be altering the anatomy. You are simply just removing the tips or the high spots of it. Okay? In the area of the socket, you're going to remove this area that is squeezing on the denture. These, if they were only the areas of pressure, what will happen? The denture later on will fit better. Okay, they were only. If I have removed one or twice, I'll usually ask you to remove them. How much am I going to let you remove? Not more than half a millimeter, maybe 1 millimeter. But more than that, I'm going to thin out the base plate, especially in the root area. I'm not talking about the area underneath teeth. Underneath teeth, I'm allowed to remove more because I have a lot of material, acrylic, beneath the teeth. But here in the ruga area, if I adjust more than twice, I will have thinning in the ruga area. This thinning might cause fracture later on. This is where I go backwards and go for relining. So it's not only removing pressure areas, it's relining to fill in the negative. But once more, the thickness I'm seeing in the material, I'm not going to rely on it because you said it might have partially set and the closed mouth technique was not sufficient. But still, through all of this, still these areas are apparent. That means they are very high. They're causing a lot of pressure. They might be interfering with the seating of the denture. So I'm not going to go for diagnosis unless I remove the high spots twice in the ruga area. After that, I will go back to the addition, not removal. So adding the other empty areas rather than removing the heavy spot areas. So I'm going to show you in a second video, inshallah, how it's done. But once more, when you fill in the material, first of all, don't leave the material thick. You make it as a wash. Don't add thick material. Even if it's light body, the hydraulic pressure build up beneath it, it will not allow it to flow. So make it thin at the beginning. Secondly, overlap all of the sulci. They should cover all, up to the polished surface, maybe to the marginal gingiva. Especially in the posterior area, where, because this is the area where the coronoid works. So I'm going to allow you to move the coronoid left and right, so it will imprint buccally if it was thick. Okay, I'll see the imprint of the coronoid, by the way. So make sure you extend, make sure it's extending all of the borders, make sure you've done correct border molding, and the mouth is closed mat technique. Once or twice of heavy spots, otherwise I'm going to do reline if all of these negative areas are still there. But just for an idea, please remove the rubber to show you how thick it is. No, okay, can gloves please? You disinfected, I know, but still it's better to use the gloves, even if it's disinfected. And this is the after removal of the rubber. Notice how thick it is. In the light, it's not even showing through. That means a lot of negative areas are there. But once more, I'm not going to depend on it. I'm going to let you do it once more with a freshly mixed material and be quick in your hand. The areas that are exposed here, we have marked them. We're going to remove them from the fitting surface of the denture, especially in the sulcus area where we have the socket, where was the socket. We're going to remove these. I'm going to allow for a second rugi adjustment, and then we're going to see or are we going to go for a reline or not. Thank you.